Hi, my name is Dr. Alyse Bedell. I'm a GI health psychologist and assistant professor in the Department of Behavioral Neuroscience and Psychiatry at the University of Chicago. Today, I'm going to be talking to you about the mind-gut connection and its relevance to IBD. So first I want to introduce you to the brain-gut axis. So the brain-gut axis is a very tangible, real connection between your brain and your digestive tract, which we call the gut. So it's a neural pathway, but there are lots of other systems of the body that are involved as well. And it's bidirectional, meaning that information can come down from the brain and information can come up from the gut. You'll see to the right that we have a description here, and it shows that things like emotions and stress are actually communicated from the brain down to the digestive tract or the gut, while things like the taste of food that you consume, the nutritional content of food, and your levels of hunger and fullness is information that goes up to the brain. So this happens because actually the brain and the brain-gut axis actually connects the cognitive and emotional areas of your brain to your gut's nervous system. And so this is a way that your brain and your gut are very intricately and closely connected and are in constant communication. So psychosocial factors are actually really important in IBD, but it's one area that can oftentimes get overlooked, particularly when a person is in a very acute state of illness and the medical management is so important. But really, these psychosocial factors can impact you both when you're in a state of active inflammation and when that inflammation is resolved and being well treated and you're in a state of remission. So one that we know more commonly are things like mental health conditions like depression, anxiety, or even stress can be a type of mental health condition. And so these are things that can certainly be problems in their own right because they're a source of suffering, but they also can influence the course of inflammatory bowel disease. So there's lots of different pathways for which this can happen, but one good example, I think, is just that with depression, if a person is really depressed, let's say that they're struggling to make it to their medical appointments, they may have less motivation, be less organized to take their medications on time. And if a person is neglecting to go to their medical appointments, neglecting to take their medication on time, that can actually end up resulting in worse disease, and so even in increased inflammation of their disease. GI-specific anxiety is one aspect of a mental health type of factor that isn't necessarily a clinical depression or clinical anxiety, and it's one that oftentimes isn't talked as much about. But this is really something that I see a lot in my patients with Crohn's and colitis. So we call it GI-specific anxiety. So that is anxiety that is actually not about things that I would consider to be general stressors. Things like worrying about your job or worrying about interactions with family members, but it's really anxiety and worry that you're experiencing about your GI symptoms or the treatment. And that's something that can also cause suffering in its own right, and it can also influence how we manage our illness or the course of the disease itself. Social support is another psychosocial factor that's important here, and we actually know that it's associated with better mental health outcomes in patients who have inflammatory bowel disease. Now, social support can be things that are types of material support, so having somebody to drive you and pick you up from your colonoscopy would be a kind of type of material support, while other types of social support can be more emotional. It can be, do you have friends and family that you feel like you can talk to about maybe some of the aspects of your disease that are not comfortable to talk about with other people? So we know that if people have those two types of support, it can be a really good buffer for helping to cope with their illness. So another factor is resilience. And so resilience is really that ability to bounce back or to buffer yourself when things do get tough. And of course, if you have an inflammatory bowel disease, there are going to be times that are tough. But folks who have that ability to bounce back have less disease activity and higher quality of life than folks who actually score lower on measures of resilience. Now, the great thing about all of these factors that I'm highlighting are that these are things that are malleable. We can modify them. So if a person can identify that this is a problem and can get appropriate support or treatment, these are actually things that we can change, which can, in its own right, reduce suffering, and it can also change the course of the IBD if these things are a factor here. So I want to highlight just one example of the ways that we can see these types of mental health or cognitive and affective, meaning thoughts and feelings, types of behaviors, can actually impact other parts of our life. So I'm going to show you what I'm titling the vicious GI stress cycle. And this is one way that we can really highlight GI-specific anxiety, that concept that I talked about in the last slide. So let's say that a person is experiencing some twinges of like an abdominal cramping before they are about to go out to dinner with friends. So a very natural thought might be to have the thought, I'm not going to make it through this dinner without having symptoms. You know, maybe diarrhea, maybe urgency, maybe just really severe pain. It's a thought that makes sense to have if you've had those types of symptoms and it's resulted in a consequence like that in the past. But nonetheless, even if it's a thought that makes sense to have, that thought influences your emotional state. And it's a negative thought, so it's going to influence your emotional state in a negative way. So that might be experiencing emotional feelings like being stressed or worried or down. It also can include physical feelings or sensations like more abdominal pain, muscle tension. That's because of a pathway that gets engaged, which is your body's stress response system. So that fight, flight, or freeze response. So when that response system is engaged, it causes changes in your body. So increases in your blood pressure, your heart rate, your breathing is going to get more shallow and rapid. And one aspect of that response is actually to experience changes in your GI functioning. So that means what started this whole process was experiencing some abdominal cramping. And now one aspect of the result of this process is maybe increased abdominal cramping, and now maybe even a sense of urgency that you do have to use the bathroom. So you can see that the thought is really important here in actually influencing your symptoms. Now, behaviors are another part of this process. So what you do to cope matters. So maybe it's paying a lot of attention, focusing your attention on those physical sensations, monitoring very closely what's going on in your gut. Maybe it's taking a medication. Maybe it's ultimately canceling your plans. That has consequences too. So we can do things that are really helpful, and we can call those coping strategies. Maybe taking a medication is a great option for you at that time. Maybe canceling plans is a good option for you, but we have to realize that there are consequences. Canceling plans actually might increase some loneliness, maybe some disappointment. That can trigger that stress response as well. So we have to look at our behaviors too and be able to see what are some of these behaviors that might be helping us, what are some of them that might be hurting us. So what do you do? Well, there's a lot of things that people can do on their own without even necessarily needing additional support from a professional. Some things to highlight. Helpful self-talk. So we talked about the importance of your thoughts in the last slide. And so you'll notice I didn't say positive self-talk here, because sometimes stuff just isn't that positive and we don't want to be Pollyanna about it, right? But sometimes there are ways that we can soften our thoughts. We can make them a little bit less hurtful and make them work towards us. So I would say identify if there are some things that you notice that you're engaging in when it comes to your thoughts and you realize this is actually making me feel more depressed or more anxious. Maybe see if you can soften them and make them a little bit more positive, a little bit more hopeful, or maybe even a little bit more realistic if they've gotten out of control. Diaphragmatic breathing is a really helpful tool for both general stress management and also for GI symptoms, and I'm going to explain and talk about that more in another presentation. Meditation, lots of folks are trying this nowadays, and that can be another really helpful tool to kind of gain a little bit of control over your thoughts, to relax your body. That's something that you can do with very little tools necessary. You can go on YouTube and actually look up guided meditations, for example. Engaging in pleasant activities is actually its own form of an antidepressant. So just doing things that you can enjoy can really help you feel better. And then physical activity, just moving, dancing around your apartment, getting a little bit more walking in, not just outright going to the gym and going and exercising. Even just little increases in your physical activity can also really boost your mood. Now, let's say that there's a situation that's not going to be enough. Well, if you really have a mental health concern, like a more severe depression or anxiety, maybe a depression or anxiety that you've had long before you even had inflammatory bowel disease, that's probably time to talk to someone who specializes in treating those mental health conditions. So this could be starting talk therapy, that's psychotherapy, that's what that means, that kind of talking therapy. That would be with someone that's a psychologist, a clinical social worker, other type of mental health professional that really works with people who have depression, anxiety, or whatever other type of mental health concern you might have. That also can involve seeking help with medication management, meaning taking an antidepressant type of medication. And those can be helpful for both depression and anxiety. That could be working with a psychiatrist, but a lot of times a family practice physician will be able to help with that as well. And there are different types of physicians that can help prescribe those medications. Now, when the concerns are more related to the inflammatory bowel disease, that's when doing psychotherapy with someone that really has that additional training and experience in working with patients who have gastrointestinal conditions can be a great resource. So we can do things like work on relaxation strategies that can really help de-escalate that stress response. Cognitive behavioral therapy has been adapted for using with patients who have gastrointestinal conditions. And something called gut-directed hypnotherapy can also be a great complement to your treatment that can really help regulate that brain and that gut, that conversation that's happening between them. Now, medications are an option too, and so we call those neuromodulating medications when we're actually using them to help with the GI symptoms. So calling it an antidepressant is kind of a misnomer because a lot of times they're not being prescribed for depression or anxiety. They're actually being prescribed to regulate that conversation between the brain and the gut. So that can be another option that can be helpful too. So take-home messages for this presentation. So without considering the brain, we are really missing an enormous aspect of what can drive GI symptoms and can impact quality of life in IBD. Medical treatment is just one part of maintaining the IBD-related health. Then managing your IBD means remembering that you are more than your IBD. And so really considering that your inflammatory bowel disease is one piece of you. It's one piece that does deserve some attention and deserves management. But if other areas aren't getting addressed as well, then we're missing out an opportunity to really maximize your quality of life. So diaphragmatic breathing is also sometimes called belly breathing or abdominal breathing. So I want to give you a little bit of background as to why we actually call it diaphragmatic breathing when we're using the technical term. So the diaphragm is a dome-shaped muscle. It's tucked under your rib cage, and its major purpose is actually to help move so that your lungs can move and so that air can move in and out of your lungs. Your lungs aren't muscles, so they actually require a muscle to do that movement for them. So when the diaphragm is moving up and down, we should actually see the belly move in and out. We aren't able to see the movement of the diaphragm just with our naked eye, so we actually use the movement of the abdomen or the belly as an indicator so that we know the diaphragm is moving. So the movement of the diaphragm is really important because when that is the muscle group that is getting engaged for breathing, it's the most helpful and efficient type of breathing. So we actually get more oxygen into our lungs when we breathe in this way, as opposed to when we breathe using our chest and shoulders. Now, when we're born, we all really are born knowing how to breathe using our diaphragm. But as we get older, there's all this pressure from society that we're supposed to have these strong cores, and we sort of all are inadvertently sucking in our abdomens a lot of the time. And so we start to rely less on our diaphragm, and we start to rely more on our chest and shoulder muscles. That actually makes the diaphragm weak. So over time, it then gets harder to break that habit because your diaphragm isn't as strong as it was when you were born. So one way that we can actually engage this is to start by using this as a physical exercise. And so by moving your belly in and out, we can actually exercise the diaphragm to get it back into shape. So when you are breathing in, your belly should move out. Just so you understand what's happening in your body, when you are breathing in, your diaphragm is actually moving down into your belly a little bit, and it's contracting. And that allows your lungs to have air full, for your lungs to be filled with air. Now, when you're breathing out, your belly is going to move in, your diaphragm is going to relax, and is going to move back up into your chest. As I said, there are some benefits to diaphragmatic breathing. One is stress management. So this is why oftentimes when you hear people talk about things that you can do for relaxation, like, oh, do some deep breathing, do some slow breathing. That's really because if we are breathing the right way, and we're breathing using our diaphragm and those breaths are nice and relaxed and slow, that can actually interrupt our body's stress response. So when your body is under stress, there are all kinds of changes that happen in your body, like your blood pressure is going to increase, your heart rate's going to increase, you're going to have stress hormones released. The only thing that you can do to intervene on that process consciously is change your breathing. So if you can actually shift your breathing to make your breathing more efficient, get more oxygen into your bloodstream, you can actually engage your body's relaxation response, the parasympathetic nervous system response. We sometimes call that the rest and digest response. So there is a very concrete and clear pathway that if you can engage your diaphragm when you're breathing, you can actually switch your body into a more relaxed state, both mentally and physically. Now, one reason why it's really helpful for people who have digestive conditions is that it can actually directly impact your GI tract. So there's one pathway, and I would say that this is the more indirect pathway, which is your brain and your gut are connected. So if you are more relaxed in your mind, your belly is going to be a lot happier as well. So that's a more indirect pathway. There are some direct pathways. One is that the movement of the abdomen as it's moving in and out creates a nice amount of space, and it decreases tension in your abdomen and the pelvic floor muscles, which actually promotes a healthy and relaxed digestion. You figure you got a lot of stuff going on in there, and the more you eat and drink throughout the day, the more space you actually need. So with that regular expansion of your belly with every breath, it allows that relaxed digestion to take place. And we just can't really do that when we're slumped over our computers, we're wearing tight pants, and then we are restricting our belly and breathing with our chest and shoulders. Now, another cool thing is that the movement of your diaphragm up and down and the movement of your belly in and out also creates a normal, natural internal massage. So just in the way that you might find it helpful sometimes to rub the outside of your belly kind of gently to promote relaxation and digestion, diaphragmatic breathing can do that on its own as well. So now I'd like to take a break and I'd like to actually model this skill for you before we talk more specifics. So you're going to see me slouching in my chair on purpose because this is easier to see when you are laying back. And so I'd actually recommend that when you do this on your own, you actually lay back completely in your bed or on your couch so that you can actually maximally see this movement. And it's especially easier when you get started. So I'm going to put one hand on my chest and one hand on my belly. And I want to be able to monitor, and I want you to be able to monitor as well, that we shouldn't actually see much movement in my chest. We should see pretty much all the movement in my belly because, again, that's how we know that the diaphragm is moving. We don't want our chest and shoulders to be moving because that means that they are doing the work that the diaphragm is supposed to be doing. So I'm going to do a few breaths and try to model this for you. So I'm breathing in, feeling my belly rising, breathing out, letting the belly fall. So you can hopefully see that the chest has really minimal to no movement, and most of the movement is actually happening in my abdomen with the belly moving in, getting nice and big and round, and then the belly sinking back into my body as I breathe out. So now we're going to talk through some specific instructions for this. So one, and I already modeled this for you, that you are going to want to probably use your hands at first as you practice this skill. I like to have people start with one hand on the chest, one hand on the belly, but as you start kind of getting that skill down, you might even want to transition to having both hands on your belly so that you can just monitor the rise and fall of the abdomen. Focusing your attention is going to be really important. So realizing that this is at first not going to be very relaxing because for a lot of people, this is not something that's going to be super easy. If you have really not been using your diaphragm a lot with your breath, then that muscle is going to be weak. So realize that it's going to take a lot of focused attention to make sure that your chest is staying still while your belly is rising. Now, I would recommend that you breathe in with your nose and then out with your mouth. This does allow you to slow the out breaths so that you can control how fast that air is coming out. We call that pursed lip breathing. So breathing in with your nose, breathing out with your mouth. But if that doesn't feel comfortable to you, it's okay to do it whatever way you want. Main thing we want to see is the movement of that belly. Now, counting. So this is kind of up to the individual, but I would recommend that our goal is breathing in for 4 slow counts, brief pause, and then breathing out for 6 slow counts. Main thing that's important here is that the out breath should be a little bit longer than the in breath. We want to make sure that we get all of that carbon dioxide out so that you have a nice, efficient breath. And then reclining, and I did model this for you, but again, this is going to be easier to do if you're laying completely flat. So really start out this practice by laying on your bed or laying on a couch, and you're going to really be able to see increased movement of your belly and really see decreased movement of your chest. So remember that this is a skill. So practice, practice, practice. The diaphragm is a muscle, and it's first and foremost just going to need exercise to get stronger. So I recommend that people start this out as a physical exercise and start out by doing it 1 to 2 times a day for about 5 to 10 minutes in each practice. As you get more comfortable and you don't have to focus your attention quite so much, maybe you can even close your eyes because you don't need to look down anymore, consider pairing it with a meditation so you can start to transition it from a physical exercise to more of a meditative practice. Work on gradually letting your breaths get longer, slower, and deeper, but don't feel frustrated if that doesn't happen right away. That's something that within each practice session, over the course of 5 minutes, you can work to get your breaths a little bit more slow and relaxed. But then between sessions, you're going to notice that it's going to get easier for them to be longer, slower, and deeper. In a few weeks after this kind of practice, you're going to find that the movement is going to be natural, it's going to be comfortable and relaxing. And when you get to that point, you are now ready to use it as a more in-the-moment stress management tool and a tool for reducing your GI symptoms.
Hi, I'm Dr. Sushila Dalal, and I'm an assistant professor of medicine at the University of Chicago. Today I'll be talking about what patients should do to stay healthy if they have IBD. It's really important that once a patient is in remission and is feeling well from their Crohn's disease or ulcerative colitis, that they actively maintain their health and they keep track of a number of important items such as vaccinations, skin cancer prevention, cervical cancer prevention, screening for colon dysplasia or precancerous changes in colon cancer, and keeping track of their bone health. In terms of vaccinations, this is something that we should be thinking about both before medications are started and sort of throughout treatment. All IBD patients should have the yearly flu vaccine. If a patient's on immunosuppression, they should have the pneumonia vaccine. There's 2 types of pneumonia vaccination. There's one called Prevnar, PCV13, that should be given first, and then it should be followed by a second one called Pneumovax, or PSV23. If a patient is on immunosuppressive medicines, those vaccines should be given at least 8 weeks apart. If a patient isn't on immunosuppression but has IBD, there's always the possibility that they may need those medications later. They should still be vaccinated for pneumonia. They also should receive the Prevnar vaccine followed by the Pneumovax vaccine, but they can be separated by a year. It's okay to receive both these vaccines, the flu and pneumonia vaccines, at the same time. Inactivated vaccines, and these are vaccines that patients may or may not have received already, are the Tdap vaccines. Tdap should be given to patients between ages 11 and 64, and then a booster is needed every 10 years. Other vaccines to check for are hepatitis A, hepatitis B, the HPV vaccination series, and the meningococcal vaccination, which is really important for our patients that may be living in college dorms. Live vaccines are ones that we do not want to give when patients are on immunosuppression. So it's important to think about these before starting a new medicine and make sure that you're up to date with these vaccines before starting it, because you may be able to get the vaccine before starting a medication. The 2 live vaccines are the measles, mumps, and rubella vaccine, or MMR. It's a 2-dose vaccine series, and it should be given about 4 to 6 weeks before starting an immunosuppressive medication. Another live vaccine that is given to patients is the chickenpox vaccine, or the varicella vaccine. Again, this shouldn't be given on immunosuppression. It should be given about 4 weeks before it's started, and it's a 2-dose series. A newer vaccine is the vaccine for shingles, or the herpes zoster virus. There's a vaccine that's approved for patients that are older than age 50. However, sometimes our IBD patients are on medications that may put them at a higher risk of this infection, and we may recommend the vaccine for patients that are younger than 50. The vaccine is given with 2 doses that are given 2 to 6 months apart. There was an older shingles vaccine that is not as effective as the more recently released one, and the patients that receive the older vaccine should be revaccinated, as this one is more effective. Skin cancer prevention is very important, and patients should be following up with a dermatologist or the primary care physician to make sure that they're having skin surveys. IBD has been associated with an increased risk of melanoma skin cancer, whether or not patients are on biologic medications. And some of the medications we use, such as azathioprine or 6-MP, are associated with other types of skin cancer that are not melanoma, called basal cell or squamous cell skin cancer. So it's really important for IBD patients to be protecting themselves from the sun, using a protective sunblock, wearing sun protective clothing, and then seeing a dermatologist for a skin exam. The dermatologist then can help you assess how frequently you should be following up with them. Cervical cancer. For women, it's really important that they are seeing their gynecologist or their primary care doctor for annual cervical cancer screening, which is different than the general population. There have been studies showing that IBD patients have higher risks of precancerous changes in the cervix and cervical cancer. So it's really important to be following up regularly. HPV vaccine, as mentioned before, is also indicated and can be given as a 3-injection series. Colon cancer. For IBD patients that have inflammation involving their colon, we know that the risk of colon cancer increases when more than 1/3 of the colon is involved. And that risk starts to increase a little bit after a patient has had Crohn's disease or ulcerative colitis in their colon for at least 8 years. After having the disease for 8 years, it's really important to have regular colonoscopies every 1 to 3 years, even if you're feeling perfectly well and not having any active disease. That way, your doctor can take a careful look for any precancerous changes and make sure that they're detected and removed if possible, so that they never cause any trouble. Bone health. There's many risk factors for osteoporosis or weakened bones in inflammatory bowel disease. Chronic inflammation is a risk factor, use of steroids, calcium and vitamin D deficiency, and malnutrition. Because of these risk factors, it's really important that your bone density is assessed. If you've been on prednisone for a period that's longer than 3 months, if you are on steroids for many months over a period of 2 years, and then for women over 65. They should have their bone density assessed. So again, in many cases, a bone density testing is being done in patients that are younger than the usual population that's being tested for it. But it's important that we think about these additional risk factors. Vitamin D levels should be checked and supplemented if needed. So in summary, it's really important that once a patient is in remission and feeling well, that they continue to follow up closely with their doctors to make sure that they stay up to date on their health maintenance and stay well. It's important to stay up to date on vaccinations and to start vaccines early, sometimes before medications for IBD are started. It's important to follow up with regular screening to prevent things such as colon cancer, skin cancer, and cervical cancer. And it's important to keep in mind bone health and check bone density if risk factors for weakened bones are present.
Hi, my name is Joel Pekow from the University of Chicago, and today I'm going to discuss with you the risk of cancer in patients with inflammatory bowel disease. Today, we'll talk about 3 types of cancers: the risk of colon cancer, the risk of therapy-related cancers, and the risk of other cancers. To start off with, let's talk about colon cancer risk in patients with inflammatory bowel disease. So patients who've had a history of inflammatory bowel disease involving their colon, whether it's Crohn's colitis or ulcerative colitis, have a risk of developing precancerous changes in the colon, what we refer to as dysplasia, and colon cancer. Several studies have shown that this risk is greater than the general population, but overall it is very low, meaning that the vast majority of people with inflammatory bowel disease will never develop colon cancer. In addition, the risk is lower now than what it was thought to have been in the past, likely due to improved treatments for inflammation and better technologies for early detection. So what are risk factors for colon cancer? This slide details several risk factors for developing colon cancer. This includes having a diagnosis of primary sclerosing cholangitis, which is a liver disease sometimes seen in patients with inflammatory bowel disease. In addition, having a longer disease duration and more extensive colitis, meaning more of one's colon involved by inflammation, increases an individual's risk for colon cancer. Importantly, poorly controlled inflammation over time also increases the risk, as well as a family history of colon cancer in a first-degree relative. On the flip side, patients who have had isolated left side disease, if they have ulcerative colitis, those who have had well-controlled disease for a long period of time without a family history and with shorter disease duration have a decreased risk of developing colon cancer. It is recommended that all patients who have inflammatory bowel disease involving the colon undergo regular surveillance by colonoscopy, and the interval of surveillance is determined by these risk factors. How does one decrease their risk of developing colon cancer? One way is with improved control of inflammation. It is known that IBD medications do not increase the risk of colon cancer, but control of inflammation over time is thought to decrease one's risk. In addition, undergoing regular surveillance by colonoscopy can decrease an individual's risk of developing colon cancer by detecting precancerous changes early and removing these precancerous changes before they develop into colon cancer. What about therapy-related cancers? And there's two therapy-related cancers to be aware of. This includes lymphoma and skin cancers. Patients who are on a thiopurine, such as azathioprine or 6-mercaptopurine, have an increased risk of developing lymphoma. Overall, this risk is very low. It is estimated to be approximately 4 in 10,000 patient years. So in the vast majority of patients, the benefit of an effective treatment outweighs that risk. We know that this risk increases with the age of the patient as well as the duration of therapy. Thiopurines also increase the risk of non-melanoma skin cancers, basal cell carcinoma and squamous cell carcinoma. In addition, some data indicates that patients who are on anti-tumor necrosis factor alpha therapies may have an increased risk of melanoma. However, because melanoma is a rare cancer, the data behind the risk of anti-TNF therapy on melanoma has been inconsistent. Finally, what about the risk of other solid tumor malignancies in patients with inflammatory bowel disease? And the one other solid tumor malignancy that is of increased risk is small bowel cancers in patients with Crohn's disease of the small bowel. However, this risk is very low and is estimated to be seen in approximately 1% of patients who have small bowel Crohn's disease. IBD has not been associated with risk of other malignancies. So in conclusion, patients with Crohn's disease and ulcerative colitis that involves the colon have an increased risk of colon cancer. The overall risk of colon cancer, however, is low and can be decreased with improved control of inflammation and regular surveillance by colonoscopy. Patients on thiopurines do have a small risk of melanoma. The overall risk is very low, and in most cases, the benefits of treatment outweigh that risk. Patients on thiopurines also have a risk of non-melanoma skin cancer, and patients who are on thiopurines should wear regular skin protection in the sun and have regular skin checks. Marijuana contains over 400 active compounds. The highest concentration of bioactive compounds comes from the resin exuded from female plants. The main psychoactive component is believed to be delta-9 THC. However, over 70 other cannabinoids have been identified. Here is a list of other cannabinoids for which the physiologic function has been studied. All these cannabinoids bind to endocannabinoid receptors. So what are endocannabinoid receptors? Endocannabinoid receptors, aptly labeled cannabinoid receptor 1 or CB1 and cannabinoid receptor 2 or CB2, are located throughout the brain and the periphery and have a role in several physiologic functions. There's 2 discovered endogenous endocannabinoids named AEA and 2AG, which are molecules that circulate throughout the body and bind to these cannabinoid receptors. The cannabinoids, when they bind to the receptors, are known to have numerous physiologic functions, including anti-inflammatory properties. What does this mean for treating inflammatory bowel disease? In animal models, activation of the cannabinoid receptors or treating animals with a combination of THC and CBD improves inflammation. In addition, patients with Crohn's disease and ulcerative colitis have an increased expression of the cannabinoid type 1 receptors in inflamed tissues. Other studies have shown that when immune cells are taken from patients with IBD and placed in culture and treated with an endocannabinoid, there are decreased signals of inflammation and fibrosis. So this data suggests strong evidence for using cannabis as a treatment of inflammatory bowel disease. What is the data, however, in patients with IBD who take cannabis? So several studies have examined this, and it is known that cannabis improves symptoms such as pain, nausea, and weight gain, and may improve social functioning, ability to work, and depression. It should be noted, however, that other studies have shown that IBD patients who use cannabis have a poorer quality of life than those who do not. That may be confounded by the fact that patients with more severe disease activity may be more likely to use cannabis. In the studies to date, however, there is no data to support that cannabis improves inflammation or disease control in either Crohn's disease or ulcerative colitis. Some may ask about CBD, and there was one study looking at CBD in patients with Crohn's disease and did not show a benefit in symptoms or inflammatory markers. A question that commonly comes up from patients is cannabis safe to use? Overall, cannabis has a very safe toxicity profile. In this figure on the right, you can see commonly used drugs or therapeutics, and at the very top is marijuana, which has a very high lethal ratio to effective ratio. However, there is a risk of dependence. Cannabis can exacerbate mental health symptoms. Smoking has risk to lung function, and chronic use can cause a paradoxical nausea and vomiting, what we refer to as cannabis hyperemesis syndrome. So what can we conclude about cannabis use in patients with inflammatory bowel disease? There is decent rationale from preclinical models, meaning animal studies and cell culture work, to support its use as an anti-inflammatory treatment. In humans, it is very effective for symptom relief. However, there is no data to support that it is an effective therapy by itself without other traditional therapies to treat active bowel inflammation at this point in time. The data in preclinical studies does suggest that activation of the endocannabinoid receptor may be a potential target for new pharmacologic treatments in the future.
This is a very helpful resource that patients can consult called the IBD Parenthood Project. This website has really helpful infographics reminding patients what questions they should be asking, what things they should be thinking about as they start to think about a pregnancy and plan one. So I'd recommend checking out this website if you're starting to plan or think about fertility and pregnancy. So fertility in IBD should be equivalent to the general population, except in a few cases. We think that active inflammation may decrease fertility. Certain surgeries, such as surgeries to remove the rectum or to create a J-pouch or to create an ostomy, might cause some scarring that can decrease fertility. However, if disease is under good control and is in remission and none of these other surgical factors are present, we do think that IBD patients have fertility that's equivalent to the general population. However, if assisted reproductive technologies are needed to assist patients in becoming pregnant, IBD medications should not affect the ability to have eggs frozen or participate in these different assistive reproductive technologies. However, it may be less effective in patients with ulcerative colitis or Crohn's disease than the general population. It's really important that patients discuss their plans for pregnancy with their gastroenterologist and with their OB-GYN before they become pregnant. Your doctors can help you plan the best way to have a healthy pregnancy and make sure that you're all comfortable with the plan to maintain medications and make sure the mom stays well during pregnancy. So planning ahead is the best way to plan for a healthy pregnancy. It's very important that patients with ulcerative colitis and Crohn's are in a stable remission for at least 3 months before pregnancy. We know that having a healthy mom leads to having a healthy baby. It's important to confirm the remission either with a colonoscopy or an upper endoscopy or another objective marker such as a stool test or a blood test so that we really know that the intestine is healed and his mom is in a healthy place and ready for pregnancy. It's also very important for patients to talk about their medications with their doctor. Most medications can be safely continued with just a few exceptions. Methotrexate needs to be stopped at least 3 months before conception. That medication cannot be used during pregnancy. Steroids we always try to minimize in IBD treatment, and pregnancy is no exception. We want to taper steroids before trying to become pregnant. If a patient's on sulfasalazine, it's important to take a higher dose folate supplement of 2 milligrams per day, which is a higher dosage that then will be found in a prenatal vitamin. Most medications like azathioprine, 6-MP, or any of the biologic medications can be safely continued. This should be discussed with your doctor to ensure that the drug levels are where they should be before pregnancy. We know that disease activity affects birth outcomes. Having active inflammation during pregnancy has a higher risk of low birth weight infants or preterm delivery. So it's very important that a mom stays well and stays on a medication regimen that's working to maintain remission during pregnancy. Most women can have a vaginal delivery if their obstetrician feels that that's appropriate. C-section might be needed in some cases if there's active perineal disease like a fistula or an abscess or a fissure, or if patient has had a prior history of surgery like a J-pouch creation. Most IBD moms can safely breastfeed their infants. The biologic levels in breast milk are extremely low and not thought to be of concern. Azathioprine levels have been studied in a small group and are very, very low 4 hours after dosing. So this is something, again, patients should discuss with their doctor and most likely will be an option for them. Babies that are exposed to the medications in utero should not get a live vaccine in the first 6 months of life. There's one that's recommended called the rotavirus vaccine. So it's important that the baby's pediatrician knows that their mom was on medication during the pregnancy. The other vaccines that infants are given, the not live vaccines, are fine and are safe for the baby, and the babies are able to respond appropriately and mount a protective immune response. So in conclusion, in order to plan for a healthy pregnancy and maintain fertility, it's really important to be in a stable remission before conception and to maintain that remission with safe medications during pregnancy. Keeping mom healthy is the priority. Most IBD medications can be safely continued with the exception of methotrexate and tofacitinib, which we don't have enough information about yet. C-section is indicated in some conditions like perianal disease or prior surgery, but not in all patients. Most importantly, patients should think about discussing this with their doctor early, maybe even years or months before they're truly planning to conceive. They should bring it up with their doctor and come up with a plan together to ensure that they can have a healthy baby.
What is the intestinal microbiome? The intestinal microbiome is a community of bacteria, fungi, viruses, and other single-cell organisms that reside in our gut. As you travel from the stomach, which is a very acidic environment and contains relatively few organisms, to the colon, the concentration of organisms increases to the point where in the colon there is close to 1 trillion organisms per gram of intestinal contents. It is estimated that there are over 35,000 species of bacteria in our intestines, and altogether the intestinal microbiome weighs approximately 3 pounds. What is the role of the intestinal microbiome? There are several physiologic functions of the intestinal microbiome, including metabolism of therapeutics, breakdown of food components, synthesis of vitamins, development and training of the immune system, and protection of the lining of the intestine. As such, it is thought that the intestinal microbiome may play a key role in inflammatory bowel disease. In animal studies, when mice who are bred on a germ-free background, meaning they have no bacteria in their intestines, are transplanted with stool from either patients with inflammatory bowel disease or healthy donors, Those that receive stool from patients with inflammatory bowel disease and are then induced into colitis with a chemical have more severe colitis than healthy donors. This suggests that the intestinal microbiome in patients with IBD may predispose to more severe inflammation. It is known that the intestinal microbiome does change in the setting of inflammatory bowel disease. It also changes with diet, medications, and other disease states. And one of the leading hypotheses as to why IBD develops in many individuals is that there's an environmental exposure such as medications or diet, and this results in a dysbiosis or a change in the community of the microbiome. And in a genetically susceptible individual, this results in inflammation. This begs the question, what if we alter our microbiomes? Will it help inflammation in patients with IBD? So why not treat with this? And these are probiotics. And if you go to the grocery store or the health food store, you know the aisles are lined with hundreds of different formulations of probiotics. Probiotics have been studied rather extensively in patients with both Crohn's disease and ulcerative colitis. And overall, there has not been shown to be consistent benefit with any probiotic for treating Crohn's disease or ulcerative colitis. Why is this the case? Well, it may be that we haven't found the right bacteria yet to treat. It may be that an individual needs more than one or a community of bacteria in order to result in improvement in inflammation. Or it may be that we're treating too late, and once inflammation has already occurred, it is unreversible by changes in the microbiome. So this brings up the question, why not treat with a fecal transplant? What is a fecal transplant? So fecal transplants are stool that is given from a donor to a recipient. Donors are screened for numerous disease states, and stool is processed and filtered prior to delivery. Most commonly, fecal transplants are given by colonoscopy, but can also be delivered by capsule, enema, or a tube placed from the nose into the stomach. This treatment is very effective for an infectious disease called Clostridium difficile colitis. In total, there's a very good safety profile with fecal transplants. However, bowel symptoms are common after a fecal transplant, including diarrhea, bloating, and nausea, which can be problematic in patients who have inflammatory bowel disease. In addition, the microbiome differs between individuals, so all fecal transplants are not created equal, and there is a potential to transfer dangerous organisms despite screening the stool. In addition, very long-term outcomes have not been well studied in patients who have received fecal transplants. If you do an internet search for fecal transplant in IBD, you'll see some exciting headlines such as these. But what's the reality? The reality is that 3 studies have shown benefit in patients with ulcerative colitis. There is not strong data in patients with Crohn's disease. The studies that have shown benefit in patients with ulcerative colitis have used an intensive regimen where more than one fecal transplant is required, and in one of the studies, daily enemas by fecal transplants were used. The therapy is only effective in some patients, and the vast majority of patients do not respond to treatment, and the sustainability of benefit is not known. All the studies that have looked at fecal transplants in patients with IBD have been short-term studies, so it's not known what happens once you stop giving the fecal transplant. Fortunately, there are several therapies in development which may offer a more predictable safety profile and potentially could be used as a maintenance therapy. This includes delivery of fecal transplants by capsule, using freeze-dried stool, which is more stable and potentially could be used at home. In addition, it's been shown that you do not even need to transplant the bacteria from donors, but you can use a filtrate from the stool, which may offer a more favorable safety profile. There are therapeutics in development which use bacterial spores as well that have been studied in C. diff colitis and are being investigated in inflammatory bowel disease. And there are also attempts to make an artificial stool or a combination of bacteria that are found in healthy donors. So what can we conclude about investigating the microbiome in IBD and altering the microbiome as a potential therapeutic? Studying the microbiome and the interaction between luminal microbes and individuals is likely to inform us of the etiology of IBD, responses to therapy, and targets for future treatments. However, there still is a lot to learn about the interaction between individual microbes and our guts before we can develop effective therapeutics for IBD targeting the microbiome. I'd like to thank you for your time and hope you enjoyed the presentation.